Building 500. Yeah.
I can make a run later today if he's missed one.
New beings I want to go after or things?
Yeah.
Probably after. Yeah, we're waiting for class because we'll be in that building.
Yeah. I'll buy if someone wants to come for extra hands. I do not overestimate my ability to carry multiple drinks efficiently.
Well, I'm great. Those just like sparkling water.
Oh, you want one?
No, they just.
Are you sure you want one? One song, one drink.
Are they in like a machine down there?
Mm-hmm.
So now we're just going to go through some research design stuff, and I'm hoping it will give you a little more food for thought for how you might apply to the proposals you're going to develop for this class. So feel free, if a question pops in your head about how this relates to the work you're proposing, feel free to ask.
Yeah, the 6 feet. Yeah.
So we'll just jump in. If we think about the structure of research, and I like this analogy of it being sort of the structure or the infrastructure. Think about building the bridge. So what is the design? And it's your plan and your structure of the investigation that you're going to conduct that's going to help you get the answers to the questions that you care about. So that's why we were kind of specific and picky and probing and poking at your questions to help you define what exactly is the design that you're after that's going to help you get to the question that you want to answer. And what does the literature say about this problem so that we are extending what we know about the problem. So design kind of has two basic purposes. It's to answer that research question, but then the other thing you want to do in the design is control for as much variance or control for any extraneous variables that could influence the data that you get. So is there any other confounders out there that could be a reason for the answers you're getting other than what you're interested in? So design tells us what observations to make, how to make them, and how to analyze the variables or the data that we get. And if you think, have you seen this hourglass analogy before? So you're going to start with some topic of interest, which you all did a great job of explaining. So you're interested in something way out here, and you're going to narrow it down. So you're going to narrow down and focus in on something that's doable for a dissertation, and something that's manageable as a first step, new investigator. And then you're going to operationalize it, and so that's how are you going to measure. And by the way, this class, I'm very impressed with what happened this morning. You guys are ahead of where students usually are at this point in this course with knowing. what you're interested in, being able to phrase questions that make sense, being able to operationalize how you might approach it. I mean, it's impressive. So good work. Then you're going to do the observation or collect the data, and then you're going to analyze it. And then you want to go back out again and say, what are the conclusions I can draw from this particular study, and then how does that go back to the broader population? And in that discussion, you want to say, like was mentioned earlier, what are the limitations of the way I had to approach this? I did what was feasible, but there are some limitations. In your dissertation, we don't allow you to have a research team that helps you collect the data. So you did what you could do. But those are things then you go generalize back. So I think we did all this. Let's see. So what kinds of questions does quantitative science really address? And when we talk about it, we talk about exploratory, and some of you were mentioning some of those kinds of studies. So what's the opinion of the group of people? What does the problem look like in this population? What is the relationship between these variables? That becomes a little more of descriptive. How is the opinion related to other characteristics? And then causal. Are there interventions that can change something? So when we talk about the major components in this process, the first one is defining the problem. And you want to describe the problem as experienced and the problem as conceptualized. So experience will be sort of your qualitative stuff, and then has somebody come up with a way to measure it? Is there some operational definitions? What are the concepts that you want to measure? And that may go back to what you think the theory of the problem is. And then you're going to come up with the research question. So you're going to do all that review of the background literature first, and then you're going to come up with what your understanding of the problem is, and then come up with the research question. And that research question should have the theory behind that problem in any potential intervention. So you may have talked about this a little bit in previous theory classes, but you usually have the theory of the problem. The theory of the intervention should be consistent with what you think the theory of the problem is, and then your measures should flow logically from there. So let's talk about stress theory. So stress, if we're talking about graduate students and the amount of stress you're under, and there's this theory of what happens to you when you're under a lot of stress. And then the measures from that would be things that would operationalize or be conceptually congruent with what you think is in that theory. So you might have some self-report measures on how stressed the person is, but you might have a biological measure like cortisol or something like that. Then your research question may lead itself to a hypothesis, especially if you are thinking about an intervention. So your hypothesis will be usually stated as the null. There is not going to be a difference between X and Y group after the intervention. But that just helps you with the design, as explicit as you can be with that research question and the hypothesis. Then it leads the reader to understand exactly what you're going to do and tells you exactly how you're going to analyze it. So then you have the intervention, that cause-effect thing, if that's the type of study that you're doing. So The intervention construct, again, should be linked to your theory, so stated to your theory. So let's say, I don't know, meditation's going to decrease the stress in graduate students. So then how are you going to measure that? And that's the operational intervention. So you're going to say, theoretically, we know that meditation decreases stress. So we think it's going to work to help these graduate students. And then how am I going to measure that stress? And it could be, as I said, a self-report and a biological measure. Does all that make sense? So then you have to decide on your sample. And when you think about the population, that's everybody that could possibly be involved or benefit from this intervention. So it would be graduate students everywhere in the world under any program for any discipline. Or maybe what you're interested in is real specific. Maybe it's graduate students working full-time getting a PhD in nursing, or graduate students working full-time getting a DNP or a PhD in nursing. So you have to be real specific about who your population of interest is. And that came up with our some of the work here. You know, is it transition of just kids with HIV? Is it transition of kids with cancer and HIV, all chronic illnesses, whatever? So be specific about what your population of interest is, and then you'll have your target sample. So the sample refers to, I'm going to try to recruit from this specific clinic or this specific part of the country or this specific university. The participants then are the ones that you actually enroll. So just to be clear on that terminology. And then you have your outcomes, and that's the effects that you're going to measure. So you're going to have your outcome constructs, which should come from your theory of the problem and the theory of the intervention. And then you're going to come up with the ideas. So like stress is the outcome construct. And then you operationalize it with the measures. And there's stress index scales, there's salivary cortisol, there's hair cortisol. So you come up with the specific measures.
So I think I might be getting the word theory confused. You're not talking about like a nursing theory that, or you're talking about our theory about what the problem is.
Yeah, that's a really good question. So we get kind of hung up sometimes in our programs, I think, of trying to teach you all these nursing theories. And I think the science these days are saying, how do I understand this problem in a much broader review of the literature than trying to force fit a nursing theory? So what is the theory behind this particular health issue that I want to address, or this particular nursing issue that I want to address? So I think of theory in a much broader sense. And then how does my understanding of that problem and all that literature and all that work that's been done around this topic, how does that inform how I think about the problem and how I think about addressing the problem, and what measures does it suggest I should use? So I think those things have to all fit together. And that's what that logical consistency language in the rubric is talking about.
But we have to all have a sort of theory as part of our dissertation, right?
You do have to have a theory, but it doesn't have to be a nursing theory.
Right, exactly, yeah.
And
something that like grounds what you're
yeah, and it should relate to this stuff. Yeah, so you should somehow fit, how does the problem fit into that theory? How does the intervention, if you're doing intervention work, fit into that theory? And how do the outcomes result from that intervention? for that problem. So that's the part that's a little bit tricky for students many times, because it takes a much higher level thinking, I think, to try to integrate all that and synthesize it and say, okay, what do I think about this? What makes sense about this? And I think it goes back to, our knowledge in changing behavior. So if we think there's a theory out there that says, I don't know, there's probably a learning theory or something that says learning should change behavior. And then it's tested over and over and over, and the data suggests that it's not sufficient on its own to change behavior. So then you go back and you change the theory, and that's how some of these other theories were developed. Then you come to the design. So who's going to get the program? That's your logistics. And then the analysis. How do you use the data to answer the question? How are you going to analyze the data to answer the question? Then after you do the analysis, you do the interpretation. So what does this mean? Who does it apply to? And again, that's going to go back to who was your population, and can I say, so for example, I think the literature surely indicates in our country that that knowledge alone for hypertension doesn't change self-care. But what do we know in Safe Foods country? I don't know that literature, and you probably do. So if your country, if the literature hasn't answered that question, then in your population it needs to be done. So that's how you want to describe the population where you did it. I think the other example of in North Dakota, she knows what's happening, but across the country, maybe it's not the same. So that's another way to tie it back. So here's what we found in this study conducted in this setting with this population, and here's what we know about how it compares to other countries, other parts of the United States, whatever, other age groups, rural versus urban, whatever. So who is it generalizable to, and how does it compare to other settings or other interventions? And then the meaning of your findings related to the other literature. So you're going to compare to both studies that found similar to you and studies that found something different than you did, and discuss possible explanations for why you found something different. And you should be able to pick apart all of these things when you do your analysis of a study. You're going to be looking for each of these areas to be clearly spelled out for you. And sometimes they do a better job of it than others, but you're going to be looking for all of these components. So once again, then you go, as we said, so you get narrow, 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 do your data collection, analyze it, say what you think it means, and then go back and try to apply it to a broader context, and that's generalizing and comparing to the other literature. So just reminder of your independent and dependent variables, because it's important to kind of have those in mind so that you know how to analyze, what to plug into SPSS. So the independent variable is if you're doing an intervention study, is the cause or the intervention. And the dependent variables are the outcomes or the effect. If you're doing more of a predictive study. Your independent variable will be your predictor variable, and your dependent variable will be your criterion variables. So just keep those in mind.
And so in my stuff,
Yeah.
the dependent variables like the trust scale and the adherence and the engagement, like the visits and stuff like that, those pieces that are different for everybody.
Both are different. So your independent variable, because you think trust is what makes a difference. You think that's kind of the intervention that makes a difference. So that's the independent variable. And then your outcomes are your dependent variables. So your outcomes are the visits, the adherence, yeah.
The fluctuating.
Well, both fluctuate.
Because trust, obviously, everyone will have a different trust.
Yeah. So think of it, the way I think of it is independent is your intervention and dependent are your outcomes. Now, to me, that's the language that makes sense, but that's because I do intervention research. If you're doing different kinds of research, it may not make as much sense to you, but
when you read, they're always like, independent is like, age or, things that don't change. So,
well, usually things, more age and those kinds of things can be covariates. But just think independent is intervention and dependent are your outcomes. And then if you're still struggling,
so like with Brittany, the independent variable is it's Brittany.
Yeah. And the pain is the dependent.
As far as SPSS goes, because even if you have this concept down, I still feel like knowing what to put where to get appropriated is a very challenging thing for me.
You're absolutely correct. So I've done two things to help you with that. The first one is in the module, anytime there's an analysis assignment, you're going to have a sheet that's got screen capture with exactly what to click on with SPSS for each step of the process. And that's posted for you in the course module. It's also posted on that virtual CRNS if it's easier to find it there. The second thing I've done is create a step-by-step video that walks you through as I'm clicking on each of the things. Because you're right.
In life, like as we move on,
Yeah.
and there's not a video.
Yep.
Is there any, how do I, as I'm doing my own things that are going to change all the time?
Yep. So two comments about that. The more you use SPSS, the more intuitive it gets to be. There are books that are helpful. They're at home on my desk is SPSS for Dummies, which if you run into, because somebody mentioned yesterday,
I was looking at that.
there are multiple ways to do some things and what makes the most sense. You will, as graduate students, have access to the CNRS webpage for a while, and those things are still, and in reality, if you end up doing research as a major part of your job, you're probably going to learn a different software package. And you'll probably, I have not done any research out of my dissertation independent without a statistician. I conceptualize things in very complicated ways, and then I need help to how to analyze it. So I've always had a really top-notch statistician who could help me. But
the expectation when we leave this program is not that we are able to function like a statistician, but that we're able to kind of set up and
ask intelligent questions when you go meet with a statistician, I think is my goal for you.
It's like John, our advisor, he was telling us when you're doing your stuff, make sure you have access to a good statistician, like when you're doing your thesis, just to double check and make sure that you're not missing something. So you're gonna still, I would assume, then need them. Like you said, asking the right questions. And stuff.
Yeah, so we expect you guys to do the analysis for this class. without them. We expect you to do the analysis with your dissertation with guidance from your committee. But
Do you
but-
find a lot of people's committees helping them with their specific
well,
stuff?
not doing it for them, but
No,
certainly as a
yeah, like
resource.
mentor, like,
Yeah, yeah.
That's all
Yeah,
we call it. Got you on speed dial already.
yeah. Yeah, these are really good questions. These are confusing terms. And then when you go to plug it into SPSS, sometimes they don't use, like, why do they have to switch up the language just to confuse you? Really good questions. And it's our goal to have every one of you be successful. We're all on the same page here. So nobody wants to see anybody struggle and not be successful. So whatever resources you need, we'll try to provide them. So I was just going to give you an example here. Let's see. This was an example of a study I conducted a few years ago. So we had a grant from AHRQ to train providers in school-based health centers on the guidelines around childhood obesity. And so we had a national sample of nurse practitioners in school-based health centers. We recruited 24 school-based health centers in 6 states and had it sort of nationally distributed. And the independent variable was providing virtual training on the obesity guidelines. And then the dependent variable was having them do chart audits to look for documentation of the components of what they were supposed to be doing. For example, documenting BMI, percentile, whether or not they came up with an accurate diagnosis, whether or not they got blood pressure percentile, and if the kid met the criteria, did they get the labs that should have been done. So that's just an straightforward example of your independent and dependent variable. So a little more about the theory stuff, just because I'm making it confusing for you. A mid or middle range theory can be something not quite as polished, straightforward ideas that stem from a specific discipline, and it lies somewhere between a working hypothesis and those grand theories. So you learned all those grand theories in nursing, and then you start doing your work on your topic of interest. You might find something that's a little more applicable to the actual questions that you're trying to answer. And so it may be a more basic or more usable structure of ideas to help guide your theory. And I think your problem, your intervention, and your outcomes should logically link together with that theory. The other important thing when we're talking about design and then analysis is to understand this whole concept of causality. So is there a cause and effect relationship? And what is the cause and what is the effect? So the cause is your intervention, the effect are your outcomes. So there are certain requirements to have this causal relationship. And this goes back to some of those kind of bizarre examples I gave you yesterday. So in order to have a causal relationship, the cause needs to precede the event. So if we say this intervention causes this outcome, then the intervention needs to come before the outcome. That makes sense. And the cause is related to the event. So that's the covariation. And that goes back to if we don't know what causes what, sometimes the preliminary work is just looking at correlations. And then there's no plausible or alternative explanation. And that's where all of your controls come in. So if we say Reiki improves pain in infants, and we don't take into consideration that they're also giving the baby maybe sucrose on a nipple, they're rocking the baby, they're giving Tylenol. Those are all other plausible alternative explanations. And that's why Brittany's question is, in addition to the whole treatment regimen, does it make a difference? So she's acknowledging that we don't just do one thing. Can you think of other examples of how you have to control for alternative explanations?
Jenny's posture and spinal tumors.
Mm-hmm. Mm-hmm. Yeah, and you can do that by eliminating those people from the sample or controlling for it in your analysis. So you just want to think about, what are they? What are those alternative things that could be? And you mentioned it with yours, the adolescents. Is it because they're adolescents? Or you know, how is trust different? Maybe it's more important. So those are the things that you want to think about. And then how am I going to control for that in my design or in my analysis? So just a few more thoughts about the causation and correlation and confounders. So correlation doesn't prove causation. It just says there's this relationship. It does not say cause effect. And so if your real question is, does this work or does this make a difference, then correlation's not the right design. And always be thinking about what the confounders should be and try to put that in either the design or the analysis. Think about your ability to manipulate the variables to answer the question. And then, is this descriptive versus explanatory, or is it testing a hypothesis? And then the whole idea of mediators and moderators. So what do you know about mediators and moderators? Anything you've learned up to this point about those?
Doesn't that change the effect size? Mediator?
Yeah, it does affect pretty much your analysis plan altogether. What is a mediator from the examples we've talked about? Give me an example of a mediator.
We talked about mine that, like, the Jordan CT scan was a mediator
Mhm.
to the
Absolutely. And treatment adherence or medication adherence is probably a mediator to viral load. If they're not taking their meds, then it's not going to work. So that's another mediator.
Confusing to me the difference between a confounder versus mediator.
Yeah. So a confounder could be something like a different medication that interferes with something, where a mediator is something that I need to take the antibiotic before I expect the blood culture to be better. It needs to happen in order for the outcome to happen. So it's an intermediate step that needs to occur. It's taking the dose of Tylenol and then expecting the temperature to go down. So I might look at doses of Tylenol that people actually take, because that's the adherence piece. But then what I'm really interested in is, did I get their pain under control or their temperature down? So those are mediators. Now, moderators. What do you know about moderators?
Like they change the outcome.
Yep, they might have an influence on the outcome. that we have to take into account. So the best example we talked about yesterday is gender. When we were talking about heights in that population, the heights of males and females were very different. So gender is a moderator that you need to plug into that study so that you can say what you know about heights in that population. And that's, it's become a pretty important emphasis of NIH because we don't have that many studies that really identify what works for what gender. And so that's an important moderator for you to consider if it's feasible. It's
That's what Kathy Jankowski was thinking for my study to look at sex. Would be maybe that would be a better secondary now.
It's a very good thought because we don't have that information, and posture in males and females is different. Yeah, it might be a really good one. Really good one. And NIH is real interested in the gender stuff. There are some things around race, ethnicity that we don't know that could be a potential moderator. So Paul Cook does a lot of work around substance abuse and alcoholism in the Native American population is very, very higher incidence. And they've looked at some of the genetic predispositions and some of the pathology and liver enzymes being different and that sort of thing. So that would be an important moderator if you were doing that kind of work. But those are the things that you want to keep in mind because like that height study where they had males and females, the mean didn't mean anything really. I mean, it didn't make sense when you combined males and females because their norms are so different. So those are what you should be thinking of as moderators. Now, when you're talking about design, the gold standard is the double-blind randomized clinical trial. So what does that mean? Two groups.
Randomized to what, and so the interventions can be given without knowledge that should impact the outcome.
So
I'm thinking of one right now that's a really good example. It's being done all over the world, but it's a PrEP study for an HIV, and you either get a shot of a medication that can potentially prevent HIV every 2 months, or you take a pill that's already known to prevent HIV every day. But so everybody gets a shot, everybody takes the pill every day, but some people are getting a placebo shot, some people are getting a placebo pill. And explaining that in the beginning when you're consenting is very tricky, but they have to understand you got to take this pill every day, even if you think it's not real, but it's double blind because we don't know, they don't know if the shot is real or the pill is real, and they're trying to figure out if having the shot every 2 months will actually be better at preventing HIV than the pill that we know works.
Yeah.
Already.
So that's a perfect example and a good description of that double blind. So the investigators don't know, the patients don't know, the people doing the outcome measures don't know, nobody knows. And that's the ideal, so that you truly can't have any bias or influence.
And even if a patient converts, so if you have a seroconverter who gets HIV, we have to refer them to a care provider in Denver. We can't keep taking care of them. And that provider actually gets unblinded because they need to know what they were really on to be able to choose the next treatment regimen, but they are sworn to not let us know, or it's kind of a very interesting.
Yeah.
So who does know? So when you get the data back and you're writing the findings.
So there's a special team that actually can be unblinded in the terms of a serious adverse event or a seroconversion. A very that team is sort of involved in a sense. But ultimately, when they stop the study, it will become unblinded. We will be able to tell. We will know, and our patients will know what they got. And the other thing that's interesting is that if we hit 175 seroconversions, the study stops because then they know that that's the magic number 4,500 people on the study overall, that 175 people get HIV on the study, they will know whether one of these things works or not. If they go to 4,500 and they don't get there, could they know what they talk about, being a null hypothesis? It might be that we don't know which one's better,
But they must know enough about the shot that it's ethical to try it.
Oh yeah, I know the shot's been known to treat HIV and prevent HIV, but what they want to know is it better than someone taking a pill every day? I think the theory is that people don't take pills every day. And those are the ones that will get HIV, and you're putting really high risk people on the study. You're putting people on the study who are actively having unprotected sex and that kind of thing. It's a great. I like it. That's why I love that. That study is such a great example of the. People actually agreeing to get a shot that they don't know if it's real or not. It's a big deal.
The other thing that happens with those big drug studies and the HIV work is another good example, is if it becomes clear even halfway through the study that one intervention is better than the other, they will actually stop the study and say, we've already got the answer, and it's like the antiviral retrotherapy for pregnant women. It became very clear early on that that was way superior, and so they stopped the study.
8 months or something into the 076, they knew that
Yeah, it was like, whoa.
30%, and they had to unblind everybody literally overnight and
Give everybody.
And make sure that all women got the actual medication.
Right. So that's when you'll have interval analysis, when there could potentially be a problem, or in that case, it was a potential benefit. It was like the problem was not getting the therapy. Yeah, and
people who's unblinded does look at the data.
It's an independent group usually that will be looking, so that then when they discover, oh wow, we've already got the answer, then they'll stop the study. Yeah, good examples. So let's talk just a little bit more about some terminology. Efficacy and effectiveness are sometimes used interchangeably, especially in the literature, and it's really confusing for students because they really should indicate very different things. So when we're talking about an efficacy trial, that is to test if an intervention works under ideal conditions. So those are highly controlled. You've eliminated anybody who might not be exactly who you're targeting, or anybody who could have any condition that would influence how it works. You leave them out of the study. It's a very highly controlled treatment and control group to look and see if an intervention works. Effectiveness is the next step, and that's a trial where you test if an intervention works when it's delivered in the real world. So you'll have the problems with adherence. Are they taking the meds? So we know, for example, in the HIV work, we know the pills work, but we also know people don't take them. So the effectiveness trial is, okay, in the real world, do they get enough doses that it makes it work? Or do we need to do something about increasing their adherence to the medication? The same is true in the asthma studies. We know the meds work, we just know people don't take them. So what additional support needs to go into it to make it effective? So just be really clear on use of the terminology. Efficacy is like your drug trial in the ideal highly controlled lab. Effectiveness is, does this work in the real world in my clinic where maybe I don't even screen them that day?
Yeah, in the study that I talked about, they always say, oh, this is supposed to be real world, but I think it's a limitation of a lot of studies when they're trying to do the real world thing, because it's not real world when you're on a study. We're paying them $50 to come in.
Yeah.
And get their shot.
Right.
And, that kind of thing. There's a lot of things that make it not real world. But the idea is that this is supposed to be, quote unquote, real world.
Yeah. And then there's this whole max-min-con principle, and that's to maximize the systematic or experimental variance, minimize the error, and control the extraneous variables. And again, that's what you're going to do in your design. You're going to try to maximize the intervention effect and minimize the error and control for all the extraneous variables. So you maximize the systematic variance by the dependent variables influenced by the independent variable, and the experimental condition should be as different as possible. So you want to make sure that they're getting the intervention and that the intervention is strong enough to make an effect. And that goes back to maybe, Jenny, your dose thing. So you give them the maximum amount when you're testing, does this intervention work? And then when you want to go down and say, okay, but how much would have been enough? Then you can do that in follow-up studies. But the maximum amount to say if this is going to work without hurting them. When we're talking about drugs, you don't want to. So a good example of that is the early work in pediatric oncology around leukemia, where we were doing the cranial irradiation, and it worked, but then there were all these bad consequences. It actually was a nurse researcher, Kai Moore, University of Arizona, kind of revolutionized the science by saying, look at all these learning disabilities in these kids that you radiated their little heads. And do we need to do that? And now that's not the protocol. So you want to maximize the treatment, but then we want to look at, how much is enough. So then you're going to minimize the error variance, and the error variance is the variability of the measures just due to random stuff. So you reduce the error through your controlled conditions and measure the dependent variable as good as you can. And that's why self-report measures are pretty mediocre. The things that you guys are talking about proposing, hospital readmission is a concrete thing. Viral load is a concrete thing. Sometimes we need to know both. So their perception of the quality of life is important to them. So sometimes you need multiple measures, but you want to make sure that you're capturing the dependent variable or the outcome as reliable as possible. And then you want to control for all those extraneous variables. So you can eliminate it by your exclusion criteria. Random assignment of an adequate sized sample is another way to control, and that's why the randomized double-blind is the gold standard. You can build the variable into the design. We talked about the covariates. You can match the participant on the variable. So if I think gender might be an issue, I can say I'll have equal numbers of boys and girls, or the block match design. So there's a variety of ways that you can do it, but you just want to think through what are all the potential possible explanations of differences not due to my intervention. So I think that's all the content I was going to do for today. Now I want to just open it up to questions as you think back on all of this information related to the studies you're going to propose for this particular class. What questions do you have?
Can I ask about my theory?
Yep, you can ask anything.
A theory in pediatric oncology that's been used a lot is the symptom management theory,
Mhm.
CSF. And I feel like that is an underpinning for quality of life. I want to reduce their symptoms.
Mhm.
That makes sense to you?
Mhm. Yeah. So, and conceptually, so here's the problem. We have to give them chemo. Chemo causes the disease causes symptoms. The chemo causes symptoms. And then these are the things I want to measure, so that you link all of it. That's fine. Yeah. It's a good example. But, and you
Doesn't
can,
have quality of life in the name of the theory, but it
yeah.
goes together.
Yeah. And you'll describe how they, yeah. Other people have questions about how you're going to have the logical consistency with your theory?
I kind of got, what happens if you connect two theories? Because I have like a whole transition theory as part of my thought of, does that transition assessment make a difference in readmission rates? Or is there a difference between that? And the other one is the Schramm or the systems perspective. Is it okay to have two?
Yes, absolutely. And you want to describe the problem in relation to both of them, and you want to describe the intervention and the outcomes in relation to both of them. So not all of your outcomes may link to both theories, but both theories should somehow link to. Yeah. I don't think I have a good example actually of blended theories, but that is very common actually. It's a nice way to link it. How about questions around design or variables that you're proposing?
When we do our proposal and say what statistical test we'll use, it's okay if we haven't studied that test yet.
Mm-hmm. Yeah.
No, like that. If mine is repeated measures, they know that I don't really quite understand that yet, but I can still name it. That's what I'm doing.
Mm-hmm. Other questions on anybody pondering moderators or mediators for your study after we talked about that? Can you think of any that fit? Let's see if I can get to that part.
I don't know what this is, but kids with cancer, some of them are getting sicker from the cancer progressing. Some of them are getting better from the chemo working. Some of them are getting more side effects from the chemo, so they feel worse. And some are getting more used to being in the clinic, so they feel better.
It's really complicated.
Yeah.
Yeah.
I don't know if those are mediators and moderators or confounding.
Yeah, those are confounders for the most part. So gender might be a moderator,
Okay.
especially related to your posture stuff. Age could be a moderator. Ethnicity could be a moderator. Mediators would be the type of chemo and the type of intervention. What did you say?
Type of cancer.
Yeah, the type of cancer and the stage of cancer.
As I see it, is the length of treatment. Is that a moderator?
Length of treatment could be a mediator. So that's, something that's part of the intervention is the treatment. Yeah.
Because you were talking about ports, would the types of ports be?
Especially related to the posture. Yeah, so that would be a mediator.
Yeah, they either have external or internal.
Yep.
With like maybe the length of the port.
Mm-hmm.
they have at Robiac Airport.
I was just thinking like how much, like, it's, like,
Mm-hmm.
Hanging out, but they don't measure it.
that might be something.
Mm-hmm.
It's just surgeon preference where it's placed in the chest, so that, and then also like where their vessels are,
Mm-hmm.
how many.
Mhm. Can you think of covariates that you guys want to include? Is there anything that you think might be a possible explanation that you want to control for?
Social intervention might be one for me.
Say it again.
Social work intervention might be one.
Oh, absolutely. Social worker involved might very much be a confounder that you'd want to control for.
So for me, it's like if they've had other evidence-based practice training.
Yeah, absolutely. What other education or even reading? Yeah, good.
So as like some of the demographics we're collecting with those then like, so I was gonna look at collecting past evidence-based practice education,
Mm-hmm.
Types of programs like a BSN type program.
That's a really good thought.
So those kinds of demographic type questions. Previous degree traditional versus a accelerated type program.
Mm-hmm.
Those are then
Yep.
moderated.
Well, you could collect those as demographics and then look at correlations and then decide whether or not you want to put them in as covariates. Or you can pick those as covariates based on previous literature. So read everything you can find, and it may say, based on this study done by whoever, that you've identified these covariates. But yeah, those are really good thoughts. You guys are thinking really, really, really well about what's all the possible explanations for the difference other than my intervention. What could influence this besides? Yeah, really good thoughts. Any other examples you guys can think of? And you know where you're headed next? I think there's lunch, and is Megan doing her presentation today? Are you headed in?
I think so. Well, I don't know how formal it's going to be, but they the board was asked somebody like speak to, to be available.
3,500 in ED1.
Across the quad there? Okay. So, any last minute questions before we wrap up for today? Questions? Sure.
You sent out the Zooms that we worked out?
Yeah.
The last one is on 12/4, 7 p.m.
Yes.
Yeah. According to the syllabus though, the assignment data analysis interpretation is due on, assignment number 3 is due on December the 3rd.
Well, that's not going to work. Yeah, how did I mess that up?
I had the same question too the week before with the research proposal. That session is 11:27.
Well,
The
let's.
research proposal is due 11:26.
I did not bring that.
But that's because we're talking about that at one before.
I don't think so, because I looked back at what, but maybe I'm wrong. So.
Let me see
From 2 weeks.
the assignments.
You just said November 27th.
13th was for the November.
Yeah, November 27th, we're talking about, November 27th, we're talking about data analysis number 3. November 13th, we're talking about data analysis number 2 and the proposal. So you're just off.
Yeah, it's the thing before that we're talking about that day.
So December-
And actually, yeah, So it's not very nice to have you turn one in on the 3rd and then the next day have you start thinking about the next, but that was the plan. And yes, our number 2 is to discuss both the analysis assignment and the proposal. Yeah, good question. Thank you, because I've been known to get confused, so I don't want to get you confused.
I have 2, which is why I wrote it all.
I thought I captured it all, but I was,
like, I don't remember what we're talking about.
yeah. And you all saw that you can see the Zoom link right here, and just click on this recurring one. So I'm just using the same one.
What was that now?
Over here on Zoom, I'm in Canvas, and over here, where did it go? At the very bottom, over here.
Hello, Linda. Oh, I don't have that.
I don't have that.
You don't have it?
Yeah. I don't know.
Must be the-
What?
Yeah, because we're always trying to figure out where to find the links. Everything's different.
Oh my gosh. All right, so I'm going to copy this.
So big, I don't remember.
Right, it's just saying, it's a competitive, generally, they expect it to.
Wonder why you don't have that. How helpful is that if it's not in there?
I feel like I'm seeing those in some classes though, so I think you can unlock what shows up in the student view.
Yeah.
Right, so I guess.
Yeah, let me see.
Like one of those assignments are showing you in the calendar view, like when they're new.
Okay, let me see if I can do that. But meanwhile, I'll put it in an announcement, the link, so that you have it there at the bare minimum. Because it would be nice if you could get there multiple ways. All right, any other questions? Tomorrow we're going to spend the first hour just reviewing some tools and things that you'll use for the critique assignments. And then I'm going to give you some work time to begin identifying an article, answering questions about using the critique tools on that article. And then if time permits, you can share some of the stuff you found. It might be longer work time and just individual questions. We'll see how the time goes. But I want you to do some hands-on practical use of those tools for those 2 critique assignments with me here to answer questions so that you're not trying to guess what I'm after. So, questions? All right, take a little break and head over.
Yeah, sorry, I was too early.
It was like all of us. And I was
Connie, can we get your feedback on our research question ahead of time?
Absolutely.
By email?
Yep.
Submit to us, or
Yep.
should we email you and ask you for that?
Send me the question if you have. So I gave you some verbal feedback. The group gave you some verbal feedback. If you have a second draft that you want to run by me before you, just send it to me in an email. But don't do it in Canvas. Do it, yeah.
Oh my gosh, that's awesome.
Yeah, traffic's really bad. Like
But I have to go up to like 20 miles, 15 miles. So it's not really in traffic. It's just I have to go I live in Van Ness, Bridge, the other side of the just where. No, but it's not too bad. I like the way that all of them, I'm like, oh, there's traffic.
See, now you have the recommendations you have to take. So you try to, 45, 50 minutes.
Hmm.
Yeah, for some nights, I was talking about my children. Probably, it's not fun being in the traffic.